Hello and welcome. This is the 50th Cervical Spine Research Society Annual Meeting, and we're very fortunate to have a great group for case discussions. First of all, I want to thank our annual meeting committee. They did a fantastic job. We hope to catch everyone up in San Diego starting on Wednesday with our in-person visit. I'd like to start today's session. We're very fortunate to have a great group. Heiko Kohler from President of European Cervical Spine Society. We have Dan Rowe, who is a past president of the Cervical Spine Research Society, and we're very fortunate to have Dr. Yong. I'm excited to hear you guys and take it away.
Good morning. First of all, I'd like to thank Professor Kohler for his invitation to this case discussion session. I'm Yong from John Tower Hospital of Nanjing, no disclosure. The case presented here is a young girl, aged 8. She looked for my presentation just for her torticollis, otherwise no other complaints. Her X-ray films show cervical congenital scoliosis with slight trunk shifting to the left side. CT scan shows it's a complex cervical thoracic scoliosis, but the driver of neck tilting is basically C6 hemivertebra. The other components of her congenital malformation, such as unsegmented T1 hemivertebrae, seems not contributing to her spine deformity. T1 is leveled. 3D printing demonstrated C6 is fully segmented hemivertebrae, but with vertebral artery passing through transverse foramen. No doubt, the patient is indicated for surgery, and the traditional way of hemivertebral resection for this deformity is combined the anterior-posterior or posterior-anterior approach based on literature. Here, I like to present a new option for cervical hemivertebral resection, which means everything is done by posterior-only approach. One important step is pedicoscleral insertion. It's difficult in very young children, but now possible with O-arm navigation. Basically, one level above and one level below, but often need for more levels to fix. The second step is a C6 laminectomy, followed by facetectomy. The nerve root will be seen clearly now. Then open the transverse foramen and cut the pedicle, dissecting the transverse process together with vertebral vessels away from its vertebral body. This is very important, maybe the most dangerous portion of the surgery. Remember, you don't have to expose anatomically the vertebral artery. With subperiosteal exposure and the removal of 2 adjacent discs, hemivertebrae can be now removed easily. During this procedure, ultrasonic cutter is very helpful. Here are some photos demonstrating the removal of vertebral body. We don't try to do in-block resection of vertebral body, but piecemeal removing. Osteotomy closing is not difficult with compression force because of a flexible cervical spine and pedicle screws. Post-operative CT scan shows complete removal of C6 hemivertebrae, and C5 is well horizontalized, leading to the correction of neck tilting. All pedicle screws are well positioned. Clinical presentation is excellent. Her head and neck remain vertical, and her shoulders become leveled. Importantly, her cervical lordosis is improved as well after surgery. No loss of correction at 1 year follow-up. Now, quick literature review. Cervical hemivertebrae is a rare spine deformity, so patient may present with earlier torticollis, head tilting, with time maybe facial asymmetry and unleveled shoulders, particularly when hemivertebrae is located in low cervical spine. All surgeons agree that the patient is well indicated for early surgery. There are some case reports in literature regarding cervical hemivertebral resection. First case report is from France. 40 years ago, the surgeon used combined anterior-posterior anterior approach for resection of C6 hemivertebra and a hollow vest for progressive correction after surgery. Dr. Ruth from Germany did a posterior anterior approach, removing hemivertebrae. Correction was assisted by forcibly bending the head manually to the convex side. He reported 3 cases with excellent results. Dr. Wang from China reported 2 cases with similar technique, but with instrumentation both posteriorly and anteriorly. The largest series is from another Chinese team consisting 16 cases but always with a combined approach. So far, we did posterior only resection of cervical hemivertebrae for 6 patients. No neurovascular complication. Clinical results are very promising, but we need a long-term follow-up to figure out the indication, clinical outcomes, and particularly neuromuscular complication. Sometimes we use laminar hooks to strengthen the instrumentation, saving 1 level of fixation. Here's another case showing the osteotomy closing and the C3, C5 horizontalizing in surgery. To my knowledge, it's the first report for the resection of the cervical hemivertebrae by posterior only approach. So some important message to take home. Early acquisition of cervical hemivertebrae by posterior only approach is feasible and effective, but best indicated for fully segmented hemivertebrae. Essential portion of the surgery include successful pedicle screw insertion, osteotomy of transverse process, and osteotomy closing. Below is our 3rd case. Thank you.
Thank you, Yong, for the great cases. And it's really very nice to see your technique. I like it very much for the young patients. So I have 2 burning questions. In your cases, when you free the vertebral artery, the anterior part of the transverse process is maintained. So have you ever seen a kinking with that vertebral artery when you're closing the osteotomy gap? That's my first question. And the second question would be, if you ever have to go for the concave side, because some of the congenital patients have a congenital bar or a fused part on the concave side. So these are my 2 questions for your very nice presentation.
Okay, thank you, Dr. Kohler. First question, I never tried to expose vertebral artery, so I didn't see very clearly artery. Sometimes I feel it where it is, but I never try to dissect it. And the second question is posterior only approach for the section of a cervical hemivertebrae is so far it's indicated only for fully segmented hemivertebrae. I never did it for partial segmented hemivertebrae. So far, only for fully segmented hemivertebrae.
Very good point. Thank you. Please, Femi.
Excellent talk and review of the literature. So I always worry about the youngest patients that come in with either, congenital problems with myelopathy or other factors. And sometimes the clinical presentation, particularly if there's a neurologic deficit, it forces your hand to act. But in a lot of cases, I tend to wait until the bones are adequate to accommodate pedicle screws and fixation. Do you have an age or a parameter that you look at on a CT scan, for example, for the optimal age at which to fix these congenital anomalies?
Yeah, regarding indication, I don't concern a lot Corbanga, but the clinical presentation is very important. So when I see the head started tilting, I will propose the surgery, because with time, patient will present with facial asymmetry. So I propose early surgery. So clinical presentation is very important.
And I also might give one point is when these curves becoming the 60 or more degrees, then you're always in a risk area. In my impression from congenital ones, to have plexus palsy, to have stretch in the nerves, because then you're missing a point of 1 or 2 years and suddenly you have 70 or 80 degree. So in the congenital, it's different from the ankylosing spondylitis patients. I'm rather go for very early, once I can tackle it, to correct it. And once the anesthesia is fine with it, and once there's a pedicle to catch, this is.
Yeah, good comments.
Usually
So
about 5 years of age, or can you wait even a little longer?
If it's 4, it's great. If I can wait a bit, as Yong said, with the head tilt, one indication. But if, for example, if I'm at 50, 60 degrees, I have to go even if it's 4 years, because when these are bigger, if they are 70 or 80 degrees, they are really can be painful, particularly regarding the rib asymmetries that will occur, and the tilting of the upper thorax, and the pulmonary function will decrease. And when you correct everything very nicely, but you have the ribs being already asymmetric, then you have high risk for compression of nerve roots, tethering of nerves. So I rather would say go very early once it is possible to tackle it. Yeah. But it's a case-by-case decision, of course, and that's so great to have the session today. That's I would like to summarize also. It was very fantastic session, great cases. I think it's the first seminar on cervical scoliosis, so it was really a big pleasure and an honor to be with you here. And hopefully we can continue this phase by phase in one of the next meetings. So thanks again on behalf of CSRS Europe for the invitation to make this symposium today. And I hope to see you all in the next days in San Diego, all of you. Press a Q also next year, hopefully when we meet together face to face. And thank you also for your great presentation.